Welcome everybody. Thank you for being here, and I look forward to spending the next couple hours talking about some interventions and effective assessment strategies for Latino youth populations specifically. Much of my work up to date, to now, has been focused on understanding risk and resilience in Latino populations, so looking at what factors what factors related to culture might increase risk in Latino youth, as well as are there any buffering factors? Are there any things, cultural values perhaps, SES, other types of experiences that might be protective for Latino youth? But along the way, I've certainly been involved in various research projects as well that have been treatment focused, where we've been trying to figure out the best ways, the best interventions, the best modes of service delivery for Latino families, in particular Latino parents. And I work in an area of California that is a very rural area of California. It's Imperial Valley. Anybody come Imperial Valley in the house? Nobody? No? It's a long way away. It's actually along the Mexico border near Mexicali and Calexico, Coachella Valley concert. You may have heard of that, the festival. It's near Coachella and those parts. But a very underserved Latino community. So we're trying to figure out what types of interventions are best for these families. I work mostly with kids who have anxiety and depression, which, as I'll talk about tomorrow in my keynote, is probably one of the psychiatric disorders in which Latinos are at highest risk, with having pretty high rates, or at least higher rates than other groups of depression, suicide, as well as some data suggesting higher rates of anxiety. So that's a little bit of an introduction about me. We're a small group, so hopefully this can be interactive. I hope we can learn from each other. I hope I'll give you some information that'll be useful, that you'll be able to use in your practice, either if you're a student or if you have a clinical practice, if you're licensed already. Hopefully I'll give you some additional strategies to think about when you're working with Latino families and their kids. But I would also like to learn from you as far as what's working for you in the work that you might be doing with Latino parents and kids as well, okay? So can I just have a quick introduction of who's in the room, and are you a student, are you a clinician, or something else? How about we'll start with you, Jacqueline.
Okay, yeah, I'm Jackie, and I'm a student at FIU, second year.
Okay, great.
Hi, I'm Noreen. I'm a student at FIU as well, on the clinical science program.
Okay, wonderful. How about over here?
I am Lourdes Suarez Morales. I'm a faculty member at Nova Southeastern University.
Oh, great, great.
I'm here to
Okay.
learn more what I can teach my students,
Yes.
and how incorporate interventions that are appropriate for Latinos.
Okay,
in
wonderful.
clinical work.
Wonderful. Okay.
Hi, I'm Melina. I work in Hialeah and Citrus Health. I'm a psychologist. I work in community-based health centers with a population that's about 95% Hispanic, mainly recent immigrant from Cuba.
Okay, very good.
Hi, my name's Delaney. I'm a second-year clinical student in the doctoral program at FIU.
I'm Dan Landauer. I'm a psychologist in Fargo, North Dakota. I primarily work in the partial hospital program there.
All right, so far I think you win the longest distance traveled. Okay.
I'm Liz. I'm the research coordinator for Dr. Comer's program.
Okay, nice to meet you.
Nikki Schatz. I am a research faculty at FIU. I'm a psychologist and I work with adolescent substance abuse prevention.
Okay, yeah, thanks.
I'm Christina and I am Jonathan James postdoc at FIU.
Oh, okay, what's your last name?
Del Busto.
Del Busto, okay. I used to have a postdoc, Christina Bustos. Yeah.
I'm Leah. I'm a first-year student in John Comer's lab at
Okay.
FIU. Hello, I'm Amanda Sanchez. I'm a third-year student also in John Comer's
Okay.
lab. A lot of representation.
Yeah, we do. Good.
I'm also representing
John Comer. Okay.
Danielle.
Hi, Danielle.
Me too.
What's your name?
Julio.
Julio.
Research assistant.
Okay.
For Dr. Comer.
Very good.
Hi, I'm Naz. I'm working on becoming an LMHC and I work in a school.
Okay, thanks.
Shamila Lozano, I'm a program manager for Youth Co-op, and we work with families that are recent arrivals to the country from Central America. So,
Wonderful.
you know, I've been used to working with the Cuban population, but not Central America so much, so I was interested in, the dynamics are very different. The families are,
Yes.
yeah.
Yes, there's a lot of diversity in our group, isn't there? Yeah. Hi.
My name is Crystal Gonzalez and I'm a case manager in the same program with Family Led. And we both work for Youth Co-op, and it's an interesting, diverse population that we're learning that is migrating to Florida quite more than we thought.
Yes. Okay. That'll be interesting to hear some of your thoughts and clinical wisdom. Hi.
My name is Adriana Hernandez. Marriage and family therapist, and I worked like 13 years doing functional family therapy until a couple of days ago, and I'm now in boarding star centers as an intake specialist.
Oh, good. Okay, good. I think we got everybody. Great, great. Well, it sounds like we have a diverse range of practice levels, some students, some faculty, clinicians. So wonderful. We could all learn from each other as we're doing this. My slides are available online. There's a lot of them, so feel free to download them as you need them. One thing I want to talk about in the beginning is this idea of labels and terms that we use and how that may or may not be important for some groups in Latino culture, okay? There's variety in terms we use. I was thinking about the terms I use and how many terms it's been. I think I used Hispanic until I was 18, and then after I was Hispanic, then I went to college and I became Latino because it probably sounds better to say yo soy Latino or Latina rather than yo soy Hispanic. And I also went to college at Berkeley where there's a bit more of a political movement, and there was a bit of a rejection of the term Hispanic because that was more of a government-imposed term, so lots of people started to adopt different labels that had certain significance for them. On the other end of the spectrum, you have people who identify as Chicano or Chicana, who it's more of a political ideology, particularly amongst Mexican Americans, that's very meaningful for them. Since college, I think I've gone back to I identify mostly as Mexican or Mexican American. When people ask me, that's what I feel most comfortable with. That's what it feels meaningful to me to say that, much more meaningful than to say a generic label, okay? It's important, I think, in practice from what I've observed, from what we know from the literature, to ask your clients about this. Before we talk more though, I want you to just take next 5 minutes, talk to whoever is next to you, and tell them or explain to them what term you use to describe your ethnic or racial background and how it is you learned that was the term to use. Okay? So 5 minutes to have a chat about it. Pair up if you don't have somebody.
People say Spanish, even Hispanic people say Spanish. I guess but it's really just because American Hispanics say Spanish. Are you Spanish? And people will say yes. So it's like we're not Spanish. We're Hispanic.
Okay. Let's have a little bit of discussion. Or did anybody learn something new about themselves or about the other person, or this process of trying to think about your own label and why you use it? What did you learn? Who wants to share? Yeah.
I felt kind of differently because I'm from Aruba, so I don't really fall under any of these. But I think generally working with people, I think that people usually self-identify from country of origin.
Yeah.
But when we have to talk about populations we work with or larger populations where people are, I think it's very regional. I studied in Colorado where everything's Latino. You would never say the term Hispanic. It has like roots in colonization, or all these other different roots. So people are very strong. They felt very strongly about that. And then coming to practice here in Florida, Hispanic is the predominant term used here. So it was kind of a shift for me to hear that being common usage here. And I do think in the United States, when we're discussing certain populations, there's variability regionally.
Yeah. There is. I think it's tomorrow I'm presenting a slide. I thought there was more variability as well. I always thought Latino was more of a West Coast term. It's not actually quite the case. It's still Hispanic is the predominant term that most people from our diverse 20 or so countries that we come from, most people tend to still be using Hispanic. There's maybe about 20% that are using the term Latino. About another 20% or so are using, they don't have much of a preference, and the rest are using the term American to describe themselves. So, but you're right, there is variability. The one place, Texas, people from Texas do not call themselves Latinos. It's a very low rate. Most of them call themselves Hispanic when they're forced to make that decision. And it might have to do with more of the relationship to Mexican, and there used to be the Hispanos in Texas way back when. But that's a good observation. So we think it's very regional, perhaps, the term that you decide to use for yourself. Other observations?
So I think also it kind of develops kind of like how you were explaining throughout someone's life. And so terms may look different depending on what stage of your life you are.
Yes, yeah. So it might vary depending on your stage of life, absolutely, yeah.
One thing we talked about is that like some people aren't necessarily asked that question as much as other people maybe. I'm often asked that question because my last name is Sanchez and I look very white.
Yeah.
So people will be like, what? Where are you from? And I usually answer half Cuban.
Yeah.
Or like my dad's from Cuba, something like that. That's how kind of I've learned to talk about it.
Yes, yes, okay. Other people? Yeah.
Kind of going off of that, we were talking about how you answer depends on how the question is asked and who your audience is a lot of the times.
Absolutely. The context might affect it, yeah. It's important, I think, to figure out to have a term that's acceptable to the child who you're working with, as well, and perhaps more importantly, to the parents, so that parents feel that they're respected. Now, or that their ethnic ancestry identity is respected. With the families that I work with, which are mostly Mexican, they usually refer to themselves by I'm Mexican or we're Mexican American. I haven't had the experience where they would get upset if somebody referred to them as Hispanic or Latino, but I know that it does happen. Maleni, you were mentioning that you've had that experience where if you call a parent a term that's not a preferable term, that could be very kind of upsetting to them and validating to them. So I think as part of good practice with Latinos, we always want to get that in check from the beginning. Okay. How do you describe your ethnic background to somebody else? That's a question that sometimes I'll open up to, or I'll encourage my students to use. You know, what does your family, how does your family describe their ethnic background? Okay. And we're going to go through some more questions that will help you get at understanding cultural identity in our Hispanic youth. Okay, so let me keep going here so we make certain we're keeping a good pace. So Hispanic versus Latino, nobody cares, keep calm, nobody cares. Well, I don't know. I wouldn't say it's necessarily that. I think some people do care, and you want to make certain you're checking into with families to make certain that you're not using a label that might be offensive or unappealing to them. Okay? Oh, and here's that slide I was talking about. Also, one thing we mentioned, or we started to talk about, there's variability, right? So there's also variability by generation level. So if you ask or look at all Hispanics and ask them what term they use, many are using their country of origin, Cuban, Mexican, Ecuadorian, etc. Others are using the term Latino or Hispanic, and then you have about 20% using the term American. But look at how interesting. It varies depending on their generation level, right? And that might be a proxy for acculturation, maybe, maybe not. Whereas if they're first generation, most likely they're going to be using their country of origin to label themselves. Second generation, so you go down from 62% to 43%. By third generation, you're less likely to use your country of origin. You're more likely to be using the term American to describe yourself first and foremost. Okay, so something to be thinking about. Also, it raises a question if parent describes himself one way and kid describes himself another way. We see that happening all the time, that kind of intergenerational conflict about who am I? What is my identity? How do I define myself? With parents saying, well, I'm Cuban, or in the kids saying, oh, I'm American. Okay, what does that mean, and how can that be used in a meaningful way in therapy? Okay, let's keep going here. All right, I'm gonna skip that one because we already went through. So what I want to do today is I'm gonna go through a series of 4 steps, which I think provides us with some kind of template as to how we can provide culturally responsive assessment and evaluation of Latino parents and kids. 4 steps, bumping this. First step is going to involve engagement. Engagement has been the focus of a lot of our cultural adaptations. I don't know if you've realized this or noticed this, but there's been a heavy emphasis in most of the adaptations that are out there on providing psychoeducation about the therapy process in being preemptive and doing what you can to make certain that your client and their family is engaged in the therapy process. So we're going to spend a little bit of time talking about that because honestly, this is one of the larger this is one of the adaptations that you see occurring over and over again in most of our adaptations for Latinos. Second, to try to identify what might be relevant themes and information, culturally relevant themes and information that you might need to integrate into your conceptualization as well as into your treatment. So in order to do that, you have to do good assessment of cultural factors. It's easier said than done. You know, we might all think we're culturally competent, culturally responsive therapists and that we do this all the time, but I'll ask my students over and over again, did you ask about cultural factors? Did you ask about what the meaning of being Latino is in their life? And I don't think it's just at UCLA. I think more often than not, many people are not asking some of these questions. And then I'll point out to my students, you're missing a whole layer of context that could be really valuable. Why? And then we'll go into a discussion. Why didn't you ask about it? What happened? Okay. So part of it is discomfort with asking these issues, not knowing how to ask the issues, not wanting to offend them for some reason by making that a point of therapy when they didn't bring it up. So there's these other issues that we work through. And part of it is made easier by helping them to have the language to ask the questions. So in that, I'm going to go through, or for this stage, I'm going to talk about the cultural formulation interview. Has anybody used it? No? Oh, good. I'll get to see. I have something to teach you. I'm going to talk about the cultural formulation interview and some of the questions that are used as part of this interview that facilitate these discussions of culture and identity and contextual stressors and discrimination. I think it's a nice format, and I'm interested to hear what you think of it as well. Third thing is to select culturally appropriate screening and assessment tools. So you want to look to the literature, and we'll talk about what that may involve, what you're looking for. And I also have a few slides in which I have looked at the literature and listed some assessments that are considered somewhat culturally equivalent assessments that might be useful for the populations you work with. And then the last part is really to take that knowledge, take what you've learned, and incorporate these cultural factors into the treatment as needed, okay? So I think that as needed part is important because my talk today isn't about adapting all interventions. My talk today isn't about certain values or that you must look for in Latinos or a certain interpersonal style that you must have with Latinos and their kids and parents. I think there's been quite a movement away from that level of training, from that type of training in which we're basically saying it's kind of a one-size-fits-all, and if you know everything you can about Latinos and Latino history and what they might be like interpersonally, then good, you're ready, you're okay, you're set to go work with Latinos, and you could adapt the interventions based on that knowledge, adapt the intervention so that it's a good match for Latinos. I think there's merit in that, but I think it's not always useful, and I think it doesn't always work to make those types of large-scale adaptations to our treatment. I don't think that's quite necessary with all of our interventions. So we're going to talk about, is there perhaps more of a middle road, some in-between, that some tips that you could use to help you decide whether or not you need to bring in the cultural piece and to what extent you might be able to bring in the cultural piece or should bring in the cultural piece. Okay? Any questions about our roadmap here? It's hot in here, isn't it? Is it just me? It's hot in here. Is there any way to adjust the air? No? Okay, thank you. Okay. Engaging the client, engaging the family. How many people work on engagement with your clients? How many people have, yeah, okay. Good, good. Sometimes people will say that's a luxury. I don't have time to really spend talking much about engagement, but in reality for Latinos, I think that's a critical element of the treatment, and you're not going to have the luxury of having them in the chair next to you unless you work on that engagement with them. And of course, this comes out of a large literature where repeatedly we're finding lower rates of service utilization in Latinos, Latino families, youth. They're less likely to use outpatient services. They're less likely to find medications acceptable, less likely to take them. They're less likely to participate in clinical trials. There's lots of no-shows. How does that no-show rate fit with your experience? About 50%? Heads or tails, maybe they'll show, maybe not. Yeah, in some of our clinics, that's definitely consistent. Sometimes we see higher rates of no-shows with some of the populations we work with. So many no-shows, and they're more likely to drop out of services. 60 to 75% from some studies drop out after just one session, okay? So again, in my opinion, this is a critical element of treatment, is figuring out as soon as you can how to make certain they're going to come back for the next session. So this may be at the time of the telephone screen that you conduct or that somebody conducts with the family, or perhaps it's going to be during the first session that you're spending time working on this engagement. I'm just going to show a couple clips of people talking about some of the barriers that keep them out of services. I'm going to have to get out of this screen though, darn. Okay. Okay.
Some of the hardest things that I feel though that hindered me from getting the help that I needed at the time was, first of all, getting an appointment, transportation, and the time of the appointment too. I feel though that if some of it would have kind of been a little later in the evening, then with parents that was working, it would be, a little easier for them. And also if the doctor's office was kind of a little further than you expected, then it kind of turns you off a little bit, because if they're saying that the doctor that they need to see is way across town and you are on a bus and you don't have money to get a cab, or if you don't have anybody at that time that you could get to take you, seems to be really the three hardest things that I really experienced as far as trying to get him the help that he needed.
Okay, let me have one more.
When we call, it's like make us feel very comfortable with the person on the other line. Be friendly. I mean, it doesn't mean it's like joke and all that, but be friendly. Don't be like harsh with the person. Sometimes when we call because we have a problem, we have the other person on the other line who's overwhelmed, and be like, oh well, you have this appointment, take it or leave it. Try to work with us. If, let's say, call and I say I need to see someone like as soon as possible, try to find out help from someone. Try to find out from some other person. Like if you don't have the knowledge, try to get someone to come to the phone and see if if it's an emergency, or if it's just that I just need an appointment. It could wait. Those are things that help a lot. Because sometimes I might wait until the last minute to make that phone call, and it's really an emergency, and they just give me an appointment for 3 months down the line, or 2 months down the line. That's kind of a long time for me to wait. So try to find out if it's really an emergency. Can I point you to somewhere else? Why don't you go and see, a hospital? Why don't you go? Not just like, well, won't be another appointment until September. Why are you telling me? It's June and I have to wait until September? Okay. I guess those things that will help a lot.
Okay. Does it sound familiar? You have any patients who might kind of have the same reaction or be saying the same things? What do you think could have been done or could be done from an engagement standpoint with these women who, one of them's talking, the first one's talking mostly about more logistical barriers, transportation, things like that. The other one, I think it's a little bit more complicated. So what are you hearing?
I think home visits for the transportation issue.
Home visits might be a good way to engage, yeah, if your clinic, your agency allows that. Exactly. Did you have a comment?
Yeah, I think what I'm hearing, it sounds like a lot of times when they make phone calls, the person on the other line tends to be kind of cold or has a bit of a kind of lines that they typically say. If you're making lots of phone calls every day, you typically tend to say the same thing. And so it may come off as a little bit robotic and a little bit less of a human interaction. And so, maybe they get that, and so they assume that when they get to the clinic, it's going to be similar.
Right.
So maybe, the tone, more of an empathetic tone, more of a friendly tone, and a show of concern.
Okay.
Asking, well, this is our address. How far does that sound for you? And things like that.
Exactly. Good. So having a more of a warmer interpersonal style might be helpful, might be useful for some families, more so than others. Yeah.
With the second woman, it kind of sounded like she wanted more also acknowledgement that maybe it was difficult to make that call, and she's putting an effort to do this, but she's not getting much back in her, in the initial step.
Yes. So just some validation. Yeah.
I think bouncing off on that is recognizing that it's hard sometimes to reach out for the help, and if you kind of get that cold person on the other line, I think it could attract people to call back.
Yeah. First impressions are important. And this is very true for psychotherapy with our families. Yes?
It sounds like there's also that idea that this might be the first time they were reached out for mental health services or things like that, so they don't know about other resources that are available, and that's something that would be helpful if other people on the other line would be able to share, here are other places in the community, because it may take them a lot of sort of effort to actually make this call and get this started, and just sort of basically this is your one option.
Yeah.
Is very off-putting.
Right. And sorry, we can't really help you now. How likely is it that they're actually going to come back in a couple months, that they're going to wait till September, that they're not going, to try to do something else, and then it just turns them off to seeking therapy if they have these types of experiences. So I really do think that there's a lot to be said about this engagement piece, and I'm going to talk a little bit more about, I think what's fair to say could be considered evidence-based engagement strategies that have been used with Latino as well as African American families and actually other low-income families as well. Let me just get back in my presentation. Okay, so some general strategies, some which you may already do. Engaging clients, 6 steps, more kind of interpersonal communication style steps. Slow down, to speak slowly, use plain non-psychiatric language, not a lot of jargon, not a lot of technical words that might be difficult to understand. We're going to do cognitive restructuring, and then we're going to have you role play, and then we're going to do some systematic desensitization. Yeah, so we're going to try to avoid those types of technical terms. Show and draw pictures to explain the model or to explain what might happen, limit the amount of information, use that teach back method. What did you hear me saying? You know, how would you explain therapy to somebody else? We just talked about therapy. I'm curious, what are you going to tell your family, your husband, your cousin, your mother when she asks you why therapy, why he doesn't need therapy, why are you taking him to therapy? Tell me about how you're going to explain it. So use that teach back method to make certain that they're understanding what you've taught them about. Use the teach back method if you're using CBT. So how does the CBT thing work? What do you think? Tell me about it in your own words. Okay, it's a nice check. Create an environment that encourages questions and participation. And one of the adaptations, Kristen McCabe's Ghana intervention, it's a PCIT intervention. One of her critical elements is asking parents, tell me something you don't like about the treatment after every session. What worked, but I also want to know what didn't work, okay? There is a phenomena, I would say, because I don't think we have the data to support it, but we could say clinically, anecdotally, perhaps we see this in our practice, where some of our Latino parents may say, yes, I understand, yes, I agree with the intervention, and all the time what they really mean is, right? Like I said, it's anecdotal. I don't have the data to support that, but it's this idea of respect, though. You know, perhaps they're respecting authority. They don't want to say anything bad about the intervention. They're trying to be different. You're a doctor, you're a therapist. They're trying to maintain that interpersonal harmony and be somewhat agreeable, so perhaps they're not going to tell you right off the bat if they don't get your intervention or if they don't think it's going to work. They just might say yes and never show up again because they really didn't think it was going to work. Okay. There's some interesting literature coming out of a couple labs which show engagement. Actually, a good sign of engagement is when parents are challenging the intervention. That's not being disengaged. That's not a bad thing. If somebody says, why are you telling me about this timeout? I don't get it. That doesn't make sense. That type of resistance, which we may have called it before, that's actually a good indicator that the parent is engaged. So think twice the next time perhaps a family that you're working with, a Latino family, criticizes your intervention or tells you that's not going to work. It may not be that they just don't like it. It may also be a sign that they understand what you're saying and that they're engaged enough to know that it might not work, and they're trying to figure out how it will or won't work in the intervention, okay? Okay, so I was saying in Kristen McCabe's intervention, one of the elements is end each session, tell me something good about the intervention as well as tell me something that doesn't make sense to you or you don't like the intervention. So requiring that to be a piece rather than having it be optional. Okay, so pictures, you know, our CBT model lends, if you're doing CBT more so than perhaps some of the other models, it lends itself nicely to pictures, explaining families in visual terms. Habituation lends itself nicely to a picture. You know, at first you get anxious, and then the more you do it, the better you feel. Certainly with kids, we have all kinds of wonderful visuals through our CBT models that tell a story quite easily. The way you see a situation depends, or the way you feel about a situation depends on how you think about it. Okay? So bring in those types of visuals to your psychoeducation to help parents understand, to make certain that they're getting it. Okay, so as for evidence-based strategies, what's out there when we look at all the literature? What do we know works? The ones that have an asterisk by them, those are the ones that have the best empirical support. They're divided up into engagement that you do before treatment begins, as well as engagement that you do early on in the treatment, as well as engagement that might happen continuously throughout the treatment. So one thing, I'll try to sum it up. One thing I'll tell you that we're learning from this is appointment reminders are nice, but it's not necessarily going to get your clients into session. You can't pay your clients to come to session. That's not going to be enough. Believe it or not, that monetary incentives to get clients to sessions, that doesn't work. That does not improve engagement. But some of the other things that we're going to keep talking about that do seem to improve engagement, get your client to session, are these things like interventions to address, brief interventions, to talk about practical barriers, brief interventions to get family members involved. And those brief interventions often occur before the first session. You get as many family members as possible on the telephone and talk with them about their child being in therapy and that you want them to have a supportive role. What might that role look like for them? Helping to make certain that everybody is on the same page as much as possible. That's a very effective engagement strategy. Family support, we talked about that. Case management, so throughout treatment, we know that things come up, that life comes up. Often mental health, there's some data out there that mental health is not seen as much of a priority as other things. Makes sense. It's a lesser priority than things like their child's education, where they're going to live, employment, so all those poverty-related stressors. Mental health doesn't compare. It's pretty low on the list, okay? So the more that you can do things to help them not worry about those other things so much, food, and their kid doesn't have shoes for soccer practice, whatever it might be, the more you can take that stress away from them, the more they're going to be able to attend to their mental health treatment, okay? And we see that more now in the literature as well. And the last one, which we'll talk about, and I have a worksheet that you'll get to do, is doing some motivational interviewing, trying to help them come up with their goals, why they want to change, and what are the steps that are going to get them to that change that they want to make for themselves and for their kids, okay? So again, the ones with the asterisk, those are the ones that we know have been effective. The ones without the asterisk, we don't have data suggesting that they're effective. The brief intervention to address interpersonal and practical barriers, I'm going to talk about this one next. Who knows Mary McKay's work? A couple people. I think she may have been at this conference a couple years ago, last year. Did anybody see her? Okay. She has a wonderful body of work showing us how she has taken, she's devoted actually much of her career to looking at reasons why families don't come to treatment, trying to understand those barriers, what's getting in the way, and trying to test different strategies to see if they make a difference in getting families into therapy. Okay, so she's used different methods. She's used qualitative methods. She's used RCT, randomized controlled trials, to test these interventions. And she has some fairly positive data suggesting if you use this set of strategies, if you address these types of things in your therapy session, early in therapy usually, then you're going to have better engagement with your client. Engagement, it goes, there's lots of ways to define engagement. We could be talking adherence, attrition, or less dropout, more completion, more active participation in session. There's variability. In McKay's work, it typically means more attendance at sessions, okay? And that's important, right? People aren't at session, we can't really do much. So these are some of the strategies that in Mary McKay's intervention are essential. First, during the first telephone call or the intake session, you're going to clarify the need for treatment or clarify the need for mental health care. And by the way, what is mental health care to start off with? Okay, don't assume that the family knows what mental health care is or what mental psychotherapy looks like. They probably have either not seen much of it or what they've seen has come from the media, and hopefully we want to dispel any misrepresentation of what psychotherapy is as portrayed in the media, right? So giving them that information, what's going to happen here? What am I going to ask you to do? Why are we doing this? What's the rationale? Why do we think your child might need care? How is this treatment going to benefit your child? Okay, so giving that education up front, demystifying the process, which can also be a very collaborative experience. It might also serve to improve the therapeutic alliance that you have with them, okay? Second part, increase caregiver investment, so parents' investment or other caregiver, and sense of self, that should be self-efficacy. So many parents, and I'll show you a slide, the next slide speaks to this. Many parents come into treatment of the Latino families I work with, blaming themselves, that it is something they've done wrong, and I usually work with moms, I don't get dads into treatment as often. Blaming themselves that they've done something wrong, that it's their fault, they haven't been a good enough mom, and that's why their child's acting the way they're acting. Okay, so there's some self-blame and some belief that if I come to therapy, if I stay in therapy, you're gonna tell me I'm a bad parent, and I don't wanna hear that. That's gonna make me feel bad, so I'm just not going to seek services, or perhaps I'm going to be more likely to drop out of services because of this fear that I have myself about my own parenting and what have I done wrong. So as soon as you can address beliefs like that and encourage parents that even if something that they did may have contributed it, that wasn't the only thing. It's not all about them. There's lots of reasons why their child might have depression or anxiety, and that they could be part of the solution. Okay, that just because they contributed to the problem, that doesn't inactivate their role now, that they're important, that their role is very important, and you need them to help their child, okay? So increasing that investment and efficacy, identifying attitudes about previous experiences with mental health care in institutions. So like the lady in the video, the time that she called up, she tried to get services, they were cold to her, they didn't seem to care. That's a pretty negative experience. I'm afraid, a parent might be feeling, I'm afraid if I do this again, how do I know your therapists are gonna be good to me? How do I know they're gonna care about my problems, or they're gonna take care of my kid, or that they're gonna be nice to my kid? So talking about those experiences, what happened, how did you feel, and how their experience with you will be different, okay? Okay. Stigma. Anybody have good ones for stigma? Stigma comes up all the time. So how do we deal with stigma when the parent says, I'm worried because by bringing them here, and I have qualitative data from our Latino parents. So of course, first and foremost, we hear often, I think you're gonna think, and other people are going to think my child's crazy if I bring them here. What am I gonna tell my family? Everybody tells me that therapy is a waste of time, that we shouldn't be talking about these problems outside of the family, that that's not okay. Anybody have suggestions?
Normalize it.
Okay.
About, other families that have come in, and it's really interesting that you say that, because that's a big phenomenon, that we here in the mental health field see a lot, and it's an unfortunate thing, but here's what psychotherapy is about, here's what it's about. And, you know, we're working on, you know, educating more people about what it is. And so, you know, I realize that it's difficult when there's all this stigma.
Mm-hmm.
And I see that, and I know that it's a tough thing. But, you know, maybe you can say this, or maybe you can, you know, do this.
Okay, good, good. I like how you went right into that role play there. Good. Other thoughts?
I think also like giving them acknowledgement for coming in the first
Okay,
place.
yeah.
And that kind of taking that initiative and the parent knowing that they're wanting support and that they're there with you.
Mm-hmm, mm-hmm. Okay, so acknowledging that was a very positive step, it's a hard step, and that you're going to be there to support them through this process. Good, good. We discuss therapy, we make analogies all the time to things like we're teachers, we're coaches, we're people who give extra support. It doesn't necessarily, everybody could benefit from a little bit of therapy. It doesn't mean that you're strange or unusual. Yes, your child's having a difficult time right now, we get that. And just like if your child wasn't doing so well in school or on their sports team, they would go for some extra help. They would get some more tutoring. They would get some extra coaching. That's what we're doing the same as therapists. Your child's having some hard times, dealing with some emotions and feelings, and we're going to give you some extra support so that you could help your child, and so your child's able to help themselves as well. And then we kind of bring in more of a strengths-based model, and this is going to make your child stronger. This will make your child more resilient. This is going to, I mean, lots of our parents are worried about education. This will make your child kind of better able to cope with the stress in school. So framing it in terms and goals that might be shared goals that they have as well, that things that are meaningful to them, as opposed to, you know, talking about it mostly from a deficit model. We want to reduce anxiety in your kid. We want to reduce depression in your kid. So what? You know, ask yourself, so what's my kid going to be able to do if you do that? How is that going to make our lives better? So we try to frame, in this conversation about destigmatizing, we try to frame it in different terms for the family. Okay? And then problem solving around concrete obstacles. What's going to get in the way? Logistics, transportation. I'll show you some questions pretty soon. So let me just show you. I think I already talked through this. This is a study that we did for Latinos. The ones with asterisks are the ones that they disproportionately endorse, more so than white people or non-Latino white. Insurance has been a big barrier. That's why they don't get services. Stigma. So stigma is the elephant in the room. Even if you think it's not, it's worth checking in and asking about, how do you feel about being here? How does grandma feel about you being here? How does, you know, dad feel about you being here, etc. And then this other one I told you about, parental self-blame, concern, a belief, I failed and that's why we're here. So helping the parent deal with that belief, correct that belief, to improve engagement. Other mental health beliefs that are cultural beliefs or seem to be culturally related that we found in the literature for Latinos, they're less likely to recognize the need for services and to minimize impairment. So their child may have, you know, many anxiety symptoms, depressive symptoms, but when you compare how much of a problem they're saying these symptoms are causing, Latino families versus non-Latino white are under-reporting or they're under-endorsing. They're saying, no, it's not. Yes, the problems are there, but it's not that big of a deal. We could handle it. It's probably going to go away. My child's shy, but this is just temporary. It's not a big deal. You know, it's kind of more of that. This is life. This is just part of what it is to be a child, okay? So part of that is true, and part of that can be healthy coping and resilience. But part of it may also mean a missed opportunity for their child to get the services that they need. So you have to really look at, what kind of impairment they're endorsing, and really are they, to what extent are they under endorsing or minimizing the problems that something like anxiety or depression might be causing for their kid. Beliefs about discipline and therapy. We have some information that suggests that Latina moms think that they should be able, so this is kind of with that self-blame thing. This is another study, okay? A different study than the last one I was talking about. The idea that they think they should be able to handle the problems on their own. I shouldn't have to take my kid to therapy. I'm just not doing a good enough job, and maybe I'm just not being strict enough. Maybe I just need to increase the discipline or figure out other ways. And because of this belief, or at least in this McKay study, they were more likely, parents who had this belief were more likely to drop out of services. Okay, if there's that belief that this is more about me and I'm just not doing a good enough job. Okay, so what might be a way to turn that around for parents? What do you think? Or how would you address that belief? Should parents be, okay, yeah.
Usually I start off sessions with families. When they say something like that they believe it's partially their fault, I always say, well, kids don't come with a manual when they're born.
Yeah, that's a good one, yeah.
They need extra help.
Yep. And then sometimes I'll get, but my other one was just fine. I didn't have any of these problems, and that's an important point. And I'll say, exactly. Okay, so it's not all about you because you're saying that the other kids were okay. Your other kids didn't have these problems. So maybe, Danielle.
And I didn't place less emphasis on like what happened in the past or what the cause of the problems are, and just moving forward. And like you said, having the parents be a part of the solution. And an analogy that I've taken from John is that if your house is on fire, you're not going to sit around thinking about what caused the fire. You're going to go and find something to put out the fire.
Yeah.
So I like that analogy too, and taking it even if you kind of know that a lot of the problem is due to the parents' behavior or the way that they're interacting with their kid. It doesn't matter because you have to focus on moving forward.
Yeah. Okay, so it stops now. That's in the past. What can we do now to be proactive and to change that pattern? Yeah. Yes.
I go back to that teacher analogy that you're not teaching you're sending your kids to school to learn, and you're not doing unless they're homeschooling, it doesn't really work. But typically you have other people who help you out with things in your child's life. You have doctors, you have all these other services that you go to. It's just another service that you need to help your child be successful.
Good. Some good ideas, definitely. So working with these beliefs. Working with the belief, parents often, Latino parents will think that their kids their kids' problems are temporary, they're situational. Oh, it's just because that teacher, my kid doesn't like that teacher and that's why they're acting out, or there's a bully at school, or it's, their brother left to go to the army and that's why these things are happening. That type, in the context of a real problem, that type of reframing doesn't make it more likely that the kid is going to get into services. Actually, the most likely, kids are most likely to get services if a parent thinks there's a biological cause to it or some kind of traumatic event that has prompted it. Now, I'm not advocating going out and telling parents that there's a biological cause to all their kids' problems or that it's probably linked to trauma. But I am advocating working with this belief that it's transient and situational and testing that belief and seeing if it's actually true. Is it really transient? Did it really just start now? Or has this really been an ongoing problem? And tell me more about that. Okay, so doing a little bit of challenging when you can here. Okay, and then some problem-solving questions. I think these are some good ones to think about, those concrete barriers. How do you problem solve them? We ask the question, what do you think about coming? What can stand in the way of getting here? How are you going to get here? Who are you going to bring? How will people feel about you coming? What's the best time? Will it interfere, et cetera, et cetera. So again, trying to do that early on so you're prepared. So you're trying to work through some of those barriers with them so it doesn't get to the point that they don't come back to treatment, that they drop out of treatment because things got in the way and they didn't know what else to do and they didn't talk to you about it either. Okay, this opens up the door to those discussions. So quickly, I'll just show you some data. So this is Mary McKay's work, 108 Latina and African American moms, random assignment to engagement versus no real engagement. And when you look at it, the darker blue, 72%, 72.7. This is the first appointment, I believe, came to the first appointment when they had the engagement strategies versus 45% who didn't have the engagement strategies. When you follow it out to actually the third appointment, if you've given the engagement strategies, 76% are still attending by the third appointment versus 40% who haven't had the engagement strategies, okay? And actually, I'll share it tomorrow. Mary has a longer study that has shown over the course of, I think, 16 sessions, these good rates continue up into the probably 60 to 80% for engagement in attendance, whereas the curve for business as usual is a pretty steep downward slope, okay? So again, there's some good reason why we might want to do these engagement strategies, particularly with ethnic minority families. There's also more strategies that could be characterized as motivational interviewing strategies. Who's done motivational interviewing? Okay, oh, many people. Okay, good. So this is the idea of helping the person figure out for themselves why they want to change, right? And helping them to set goals for themselves and to figure out, kind of what are the pros and cons of them making the change, what might get in the way, how are they going to address it. So it's, in some ways, it's very overlapping with what we were just talking about, some of these other strategies. But I think Matthew Knock, who developed this intervention for kids with disruptive behavioral problems, has done a good job of trying to try to standardize this method, these strategies, in a way that's deliverable by therapists. So what you have, and just so you know the results, youth with behavioral problems in a treatment study, he got improved treatment motivation, more attendance, greater adherence to the treatment as well. So what you have in front of you, in one of your handouts, it's called the Change Plan Worksheet. Hopefully, it says Cool Kids on the top because we used it for a treatment study that we did. And those are the different steps to it. So I want you just to read through it with a partner. Somebody could be the patient, somebody can be the therapist. Pretend that you're a patient, that there's some kind of barrier, some kind of problems, some issues with adherence that are coming up, and one of you can take the lead in trying to help that person set goals and to figure out things that might get in the way of them completing their goals. Okay, so let's do about 5-10 minutes of that. All right, great. And I'll come around and see how it's going.
I want to figure out why. I want to figure out. How much trouble did you have making it to our session? If we're thinking we're going to be waiting for a little while.
Right.
Do you have any one of your, one thing that we
Okay, if you haven't switched, go ahead and switch now, so each of you has a chance being therapists.
So you have a break at 3:15, correct?
Okay.
Oh, I
didn't know. I didn't know we did, but yeah.
I think that's what happened yesterday. I think it was 3:15, and then they have a little break, and then they come back, and I think you're here. You're here until like 5, I think.
Okay.
But I know that the young lady there with the glasses and
Danielle,
black, she's been helping out a lot with the crew and everything, so she might know more than anything about the schedules.
Okay, I'll check in with her. Okay. So now that you've motivated each other fully, how was it? Any observations or comments you think it'd be helpful to use some of these questions with kids, with parents? Yeah.
How
Yeah.
is this implemented?
Yeah.
It felt a little bit, how do I say this?
Prescribed?
Yes, and not fluid the way motivational interview kind of feels,
Yeah.
where you're following through. So kind of trying to get through this agenda, but also responding to where the family's at, which they may not be at the stage of change where we're here.
Yeah. So typically it's been implemented in the start of treatment, and then you do it again in the middle of treatment as well as near the end of treatment. So you do it multiple times. So it's going to vary. Your tone as well as what you know about the client is going to vary depending on their stage in treatment. So as you're doing this, you may know, oh, we've already tried this. We've already tried to get dad involved, or we've already tried, doing telephone visits. So you bring in that information and you make it more conversational. There's nothing that says in practice that it has to be. What's that?
This is administered as how is it?
An interview format, yes. So you bring your clinical style to it. That's fine to do that. And ask them just, the changes I want to make are, ask it more as a conversational question. That certainly, I think, would be recommended. This is just a guideline for you to start to get to the points. So tell me, you're here, what kind of changes are you looking? What do you hope to get out of therapy? How about for you? How about for your child? What kind of changes are you looking to make? And then, they'll give you some reasons. So what are the reasons? Why are those changes important to you? Tell me. And you might need to do some prompting. Is it affecting, do you want your child to be more respectful? Why? Why is that important? Do you want them to behave better in school? Why is that important? So facilitating it and bringing your clinical skills in to facilitate some probing, some clarifying, so you could get at some of what their underlying motivation might really be. Okay? And that's important in those moments when they're not doing their homework, when they're not coming to session. It's important for you to think back, or to bring out the sheet and say, well, listen, remember, this is what we talked about. And you told me it's really important. You want them to graduate because you never had a chance to graduate. And the only way they can do this if they can manage their stress better at school. So let's go back to that. What do you need to do to make this happen? Okay? So absolutely bring more of a therapeutic style to this. This is a guideline. Okay? Danielle, I was told there's a break typically. Is that true? Mm-hmm. Okay. So how about we take I think it's a good time. Why don't we take a 10-minute break? Great. Thanks. Okay. So this is just one of those self-reflection kind of questions that I think is important for the work we do, as well as for conducting assessments with Latino families and kids, to ask yourself, how important do you think culture is in understanding human behavior? So do you tend to think it's at the extremes? So it's not important at all. We're all human. That's what's most important. We have more similarities. We all kind of share the same issues and problems in our life. Or do you have the opinion that, culture is pretty important. You can't understand any human behavior unless you're thinking about culture's impact on it. And of course, you could be somewhere in between. Thing to self-reflect about is, if you're at the extremes, that's as an exercise in self-awareness, that's probably where more of your biases are going to come from, right? It's more of, I think, a potentially risky place to be if you're in those extremes, the 0 to 25 or the 75 to 100. Because, why? Because why? Thoughts?
I guess if
Yeah.
you're in 0 percentile, then you yourself and the clients you're seeing. And if you're in the 100
Yeah.
percentile, then you're already probably maybe making your own biases about how that person might be based on their culture.
Right. Right. Good.
And you also might be making assumptions without asking questions.
Exactly. Exactly. You might be making assumptions. You might not recognize that there's a middle road, that there's a tension between everything being universal and everything being culture specific, and that it's much more complex than that. So I think all of us need to check ourselves and think about, where would how would I answer that? And if, like I said, if you're at those extremes, you may need to be more cautious about assuming too quickly and potentially missing important information as part of your assessment practices, okay? Good. That said, we know that there can be culturally relevant themes that affect Latino kids as well as parents, okay? We know this from the literature. We know that things like acculturative stress are very much linked to mental health outcomes, internalizing symptoms, externalizing symptoms. We know that discrimination is linked to these types of less favorable mental health outcomes. We know ethnic identity can buffer the effects of discrimination. If a person has a strong ethnic identity, then even though if they experience discrimination, they may not be as much at risk. So there's important things that we know about these relationships that will be helpful for us when we're trying to understand how much at risk the patient might be, how much at risk, or how much are these cultural factors really contributing to their risk for these different types of problems, okay? And that said, if you understand risk better, what else can you do better?
Assess.
You could assess better, yeah. You may spend more time on some of these factors that we know might be really important.
You can support like strength and resilience.
Yeah, you could strengthen resilience around these topics that might be, or these areas that might be something that they've experienced that is causing a problem for them. But you can also, to a certain extent, your conceptualization, your assessment can inform your treatment planning too, right? So if these factors are there, or if certain risk factors are there, then you can bring in some of those risk factors. You could emphasize it more or less in your treatment as well. For many Latino families, they may not have any of these risk factors. They may not have an immigration history that was particularly difficult. It may have been very smooth, and being in the U.S. is a wonderful thing, and they're very happy here, and they're not having problems, and they're not being discriminated against. And they have a good ethnic identity, and so on and so forth. So for those people, you're not necessarily going to be spending a lot of time talking about culture. However, if you were in the 75 to 100th percentile, you might want to. You might keep looking. You might keep thinking there has to be something I'm missing. There has to be, some cultural piece there. Maybe they're just not in touch with it. So that's why I say be cautious if you're in those extremes, that you're not making more of what it might be. But again, these could be very important areas of culture that you want to check in about, okay? How many people feel like you regularly check in about things related, when you're working with Latinos, things related to immigration or acculturation, loss, trauma they've experienced that might have come with the migration process, cultural-related beliefs about mental health? You do? All right, good.
The struggle is that we don't have good theoretical guidelines for how now that we know this information, how do we incorporate the information into treatment conceptualization and the interventions that we use?
Yeah.
There's a big gap.
Right. No, I recognize that. Yeah, I think that gap is still there. We're getting a little bit better, I think, about assessing and trying to figure out what is part of the conceptualization, okay? So are there other things I'm missing? That's what my others question was. Are there other things, do you think, that are particularly important when you're working with your Latino families that you would like to assess that aren't up here? Okay, yeah, family dynamics. Are you leading towards that, like, intergenerational conflict, or just how everybody gets?
Lots of different things, I guess. So it could be like parents immigrated, child didn't.
Yeah.
How parents view their parenting roles, how people who aren't parents are also involved in parenting.
Right.
Everything related to family.
Right. What does a family look like? And that might lead to very rich information about the value they put on familismo. It might lead to information about, like you're saying, if there's distance between them because of cultural distance, because your parents believe a certain way, they had a certain upbringing, you have a different one. It might be important with regard to parent expectations of what it means to be a good child. Yes, good one. Yeah.
I was gonna say also values, kind of in general, like what are their core main values, whether it's family, and if it's family, is there going to be an issue with kind of family supporting the treatment?
Yeah, and you could get at that in various ways, and we'll talk more about that in the upcoming slides. Yes.
Disciplinary strategies, and I feel like I've struggled in the past to meet families where they're at and come to like a middle ground in terms of what we'd recommend versus their common disciplinary strategies that they prefer.
Right, and that's if you go to Kristen McKay's PCIT intervention, part of it, I'm not certain if I presented in this workshop or tomorrow, the initial phase is checking in on parenting practices. What do they think about discipline? What do they think about rewards? Those are cultural factors, or those are factors about the intervention that can be affected by culture. So there's an assessment part that goes prior to PCIT in the Ghana intervention. Yeah. Yes.
I also like to ask about the role in the community, because I think that can inform some of their beliefs about mental health and help seeking and things like that.
Yeah.
If they think they're seen as some paragon of the community or something like that, or if they have if their support system is small or large in the community.
Absolutely. Absolutely. All really good questions. Yeah, one more.
Also like religion and how that relates to
spirituality, religion, how important is religion to them? Yeah, because that certainly will come up and can come up in treatment as well as help seeking and resources that they use. If they have this fatalism has always been one that we talk about, perhaps it being more prevalent in Latinos. We don't have strong literature to support that, this idea that they're just resigned and, whatever God says, that's what's meant to be. A little bit of that, but it's not a strong research finding just yet, yeah. But certainly understanding if it is, what does that mean for therapy and how do you work with that in therapy, yeah. So how, there's different ways to learn about these cultural factors. There's different ways to assess, you get trained in graduate school or whatever to do cultural assessments, and the hope is that, if you're trained, if you're culturally competent, culturally responsive, that you're going to ask the right questions. This is what we've relied on for, a large portion of our history in doing this kind of work and trying to be culturally responsive. Unfortunately, what we found is that there's great variability in how people are trained in cultural competency, and much of this type of questioning that we're talking about relies on having the skills and understanding the questions to ask and having the language to be able to ask some of these questions about culture that may not come easily, okay? So not all therapists may have these skills. Consequently, what happened in DSM-5 is that there was a work group led by the Roberto Luis Fernandez and others, in which they tried to make changes to various parts of the DSM regarding how culture was incorporated into the DSM, as well as how we assessed it, how we asked questions about it. So out of this new version of DSM-5 has emerged what we call the cultural formulation interview. Has anybody used that just yet? Okay, I'm interested to hear what you think about it. It's being used more and more, and more people are being trained on it, students are getting training on it. It provides a method where I think we didn't have much of a method, like you were saying, about what questions do you ask? What questions are important? So it provides a method for asking questions about how people define their problem, how they understand the cause of their problem, what are the reasons, what are the forces that are contributing to their problem in their self or their child, what supports they have used, what cultural factors might affect the way they cope, whether or not they seek help, to the extent that there's stigma there, et cetera, et cetera. It has modules that are specific to adolescents, to immigrants, as well as to kids. So this is an interview that can be used really for anybody who has, it could be used for anybody. We all have culture. So it can be used across people from different backgrounds, races, creeds, sexual orientations, etc., to better understand how these cultural forces might influence conceptualizations of problems, as well as help-seeking behaviors and risk for different problems, okay? I'm going to just go through a few of the domains, and then we'll watch a short video of Dr. Luis Fernandez kind of engaging in the cultural formulation interview with a patient. She's an adult patient, but I think you'll get the gist as to how the questioning can work. So the first one, so these 4 domains are important to it, right? The first domain is how they define the problem. So asking questions. Now this is very stilted conversation. You're able to tailor it to a style that's comfortable to you. People understand their problems in their own ways, which may be similar or different to how doctors describe the problem. How do you describe your problem? So here, asking this question, you're paying particular attention to potential cultural concepts of distress that we see in Latinos. We see these things more so in Latino adults. I'll tell you, the literature is not real rich that these types of syndromes exist to the same degree in kids. So things such as, how many people know nervios and ataques and susto and more of the somatic symptoms? Okay. So nervios is, this idea of feeling sad and worried and stressed, and you might have lots of physical complaints at the same time. Ataques is people, when they describe, they have, like a sudden fits of rage or anxiety where they feel like they lose control, and sometimes they might experience depersonalization, like an outer body experience when they have an ataque. Some people with ataques, it's actually panic disorder, but not everybody. Sometimes people have ataques and it's not panic disorder. It's just what we call, it's a cultural way to express that they're having distress. And it might be perfectly acceptable within their culture. And if that's the case, then they might be very less likely to seek services, to try to do anything about it, okay? It may not be a problem. Susto is when somebody has had some kind of fright or some kind of traumatic experience, and they link their depression, their anxiety that they're feeling afterwards to that fright that they had. That fright has stolen their soul. It's taken something from them, and because of that, they can't be themselves anymore. They can't be happy anymore. That's susto. And then other conceptualizations of illness that you might get is people being incredibly, or kids, parents being incredibly somatic, or describing their child's symptoms as being mostly somatic symptoms, not really talking about thoughts and worries and fears, but more so talking about they have lots of stomach pain, they have headaches, they have backaches, I don't know where it's coming from, it seems like it happens when they go to school, but they're not using our conventional terms like worry or anxiety or depression, okay? So in this part of the interview, I mean, that might be some things that you're looking for. You know, do they have a different way of understanding their child's illness? Is it conceptualized as something like nervios or susto, or is it conceptualized more in a somatic way? Okay? You're looking for how they might understand. What are the causes? Why do you think this is happening to you? What do you think are the causes of the problem? Are there any kinds of supports that make you feel better? Like from family, friends, or others? Are there stresses that make your problem worse, such as difficulties with money or family problems? Okay, so again, you're trying to get a better sense as to what they are seeing as the reason behind why their child is feeling this way. Okay, you could do it either with kids or adults. Typically, I ask some of these heavier questions with adults first, and then I'll check in with kids, or the parents first, and then I'll check in with kids about their support system. What do you think this question helps you with? Why do you think these questions are important?
Finding their coping mechanisms.
Yeah, what's been effective for them? What are their stresses? And are any of their stresses culturally related? Okay? So you're gathering important information about what their support and what their coping looks like. The interview also has questions specifically about cultural identity. It starts off with a description of what is cultural identity. By background or identity, I mean the communities you belong to, the languages you speak, where your family are from, your race or ethnic background, etc. Again, you could edit this. For you, what are the most important parts of your identity? Tell me about that. Tell me about your background. Are there any parts, and this is a key question, are there any parts about who you are, about that background, that are making your problem worse? Okay? That helps you really shape your conceptualization as far as thinking about culture's impact and how much of a variable is culture going to be in your conceptualization. Okay? All right. And then there's a section that asks questions about help-seeking behavior. So people go to different doctors, helpers, healers. In the past, what kind of treatments, help, advice, or healing have you sought for your problem? Has there been anything that's prevented you from getting those services? Okay, so it's just tapping into what are their patterns of service utilization, what have they used already, what's going to get in the way. You're thinking that these are things that might affect their engagement. Okay, so you're getting valuable information up front. And then, so that's for the past, and then you're also asking questions about currently, what are you doing, what's been helpful for you in working with these problems, what kind of services are you currently seeking, have you thought about seeking? Again, just to get a better sense as to what types of barriers that they may begin to experience with regard to getting treatment from you. Okay? So when people have used this interview, it takes about 15 to 20 minutes. It is similar to other intake procedures. It's a little bit similar. So it's a little bit redundant if you're using it at the same time as another intake procedure. Probably it's best if you take some questions that are most useful to you and supplement your standard intake with some of these questions. But the good news is is that when we use this interview, what we're finding is that we get lower rates of misdiagnosis of certain problems, particularly in immigrant families, as well as greater patient satisfaction. So when you're doing this kind of more thorough, comprehensive assessment of cultural issues, that is potential, it's at minimum producing greater satisfaction, that people like it, that people like being asked these questions, as well as reducing the chance that you're going to misdiagnose people, especially if it happens to be in the psychotic disorders category, okay? So let me just play a little bit of a video of Dr. Luis Fernandez doing this interview. Okay, let's see.
Yeah, that really bothers you. I get that part. Now, I'm going to switch a little bit and ask you about something else.
Let me see. So this is a woman who, she's Mexican. She's an immigrant. This is a video from a couple years ago, but her major issues are she's undocumented status. She's an immigrant. She's having problems with her family. She's very upset with her family because they called the police to her house, which could have been a very life-threatening situation for them. And she's very upset that how could her family, there's somebody in her family did this, and how could they have done this to her? So she feels betrayed by her family. Okay.
Sometimes aspects of people's background or identity can make their problem better or worse. Like in this case, it could make the feelings that you have about this fight with your cousin make them better or worse. And by background or identity, I mean, for example, the communities you belong to, the languages you speak, where you or your family are from, your race or ethnic background, your gender or sexual orientation, and your faith or religion. These are all parts of background or identity that I'm talking about. Now, for you, what do you think are the most important aspects of your background or identity?
For me, it's really important that the unity of my family.
Yes.
You know, and not get involved with the police or police. And also, as a mother, I have a responsibility. And I have to take care of my children. And I am not doing that right now because I cannot sleep. I feel really tired all the time. I'm sleeping, I'm eating too much. I'm really concerned about what's going on, and that doesn't allow me also to take care of my parents. And to be honest with you, I'm not really a good wife either. I just want to lie on bed and forget about every single thing. And also the fact that I am not allowed to be outside right now and doesn't have the opportunity to talk with these women that were kind of support me for a long time right now.
Which women are we talking about?
With my support group.
I see.
And with my family also. And it's the only time we can really speak our language. I mean, I speak Spanish all the time at home. But it feels like I belong to some group when I have that opportunity.
Yeah.
And I like to cook for my family and be there.
Yeah. It sounds like in the past, when things were good in your family, then these women were really helpful and it was a real good place to go. But now that there's been this division in your family, you can't really trust them so well, and that's one thing that you really miss.
Yes, I miss that, but at the same time, I don't want to be out. I
Yeah.
feel like I don't have the energy to do the things that I used to do and cook for this group or for my family.
Right. And it sounds like parts from what you've said, parts of your background and identity that have been affected, that are affecting your situation with your family and the feelings you have about it? There are a number of them. The fact that you're undocumented is affecting it. That your role as a mother and as a wife are, your concerns about that are affecting it. The relationship you have with your family, the importance of your family in your life. These are all aspects of things that are really connected to how you feel about this problem.
And also the fact that every Sunday we go to church.
I see.
And my husband had me suggested that I have to go with my priest, but I'm not going to do that because my cousin is talking with him.
I see.
So I don't know what how to explain things to him,
I think in some ways this difficulty with your cousin has made it really hard to know who to trust. You're sure of your husband and of some of your sisters, but it's hard to be sure of other people.
That's true, yeah.
That's hard. Now, are there any other aspects of your background or identity that are causing other concerns or difficulties for you?
Yeah, well, I don't want to be back to my country.
Yeah, right.
Nothing,
Yeah, you came here to build something.
Exactly, yeah, I came here to have a better life and, get a better job and help them, and I cannot just go back and say, I'm here without nothing because they support me.
Yeah.
And plus, they support me because our cousin was
Right. Yeah, it'd be a double problem. You not only would be deported, but you're deported because your family didn't back you up, in a sense.
Yeah, and because my family is really important to me, I don't want that to happen.
I guess it would also affect the family in Mexico if that happened.
Okay, so let's stop here. So this is just Dr. Luis going through this cultural formulation interview to try to extract information that would be important for this person's case presentation so that you have a better sense as to what themes you may need to focus on in treatment. What themes do you think are coming out of this that you're learning from this type of assessment that might be important targets in treatment? Yeah.
Values in terms of mentioning that it was somebody from her family who called the police, and so that, for her that's a big betrayal because it's part of the family.
Yeah.
If her value happens to be that no, you don't call the police on your family, or when she mentioned gender roles or her role as a mother, her role as a wife.
Yeah.
Those are also themes that are coming, but also I heard a lot of somatic, I feel really tired and I can't get out of bed, and she's describing what could be depression. So,
Okay.
But she's doing it with somatic words. So.
With mostly right, rather than some of the I feel sad or I feel worthless or I don't like myself, not so much. It's more of the physical symptoms. But yeah, I think this theme of the family support, I mean, you're getting a sense that family value is important. You're not making an assumption. You're getting a sense, because you're asking the question, you're getting the sense that this is an important theme in this woman's life, and this is a theme likely that I'll need to address in therapy. Without her family, what is she? With that betrayal of her family, she feels lost. Where, this emerged because you're gathering the data and you're asking the right questions. Other thoughts or observations about themes?
It seemed like failure, that she feels she's a failure and that people have failed her.
Okay.
Sort of this spiral.
Right. So certainly that's there, not necessarily culturally influenced, unless, if we go back to she feels, if there's some kind of gender role that she has to be kind of the super mom, the super wife, then expectations might be related to that cultural role. Yeah.
Seems like it's clear, going back on what they mentioned about values, like the communal aspect of it, and so how she mentioned that it's distressing for her to not be able to participate as part of the community and with the support group.
Yes.
Because of her, how tired she is, or her lack of energy.
Right. So that goes back to the comment you were making earlier. What is a community support? What's the community's role in this person's life, and how do they depend on the community for their resources? And without that, how is that going to affect their depression, their anxiety, whatever it might be? Okay, so I think it's a method. Again, this is just an example. What I'm trying to convey is I think this is an effective method, and I gave you 2 handouts. One is actually the cultural formulation interview and the questions, and the other one is the supplemental model or modules for adolescents, immigrant families, and kids. I think it's a good guideline to help people think about what kinds of questions should I be asking to tap into some of these cultural constructs that might be really important for their mental health. Okay? Is there questions about this? Yeah.
Something about practically if you have sort of a parent and a child,
Yeah.
it would seem like it would be practical to maybe do this with both, the parent and the child. It would seem like it would be important to do so.
Yeah.
Are there ways to blend it? Or?
Yeah, you could pick the most relevant questions. So what we've done is we've picked the most relevant questions on cultural identity and help-seeking behaviors. We've picked those questions and done them separately with parents and kids. That's the best way we've done at blending it. It's hard to do it with them in the same room.
That was my next question. Has
Yeah.
it been done where you do it in the same room?
No, we haven't.
Creating lots of different
Yeah.
problems.
Yeah. So we've just picked questions that we thought were most important and done it separately with families. Yeah. Okay. Yes.
I think something that came up that I think it's not emphasized when in regular cases or not talked about is the pressures in Latinos to not only for women that they need to take care of their children, the husband, but also they need to take care of their parents.
Yeah.
And all the stress that it's so unacceptable for you not to take care of your parents
Yeah.
if you're Latino, for you not to take care of your elderly aunts and uncles and
Right.
not have kids themselves. And so I feel like the Latino parent is not only a parent to their children, but they also become the parent to their parents.
Yes. Yeah. And I think in this interview, or this format, it does a good job of asking what is it about your culture that might be distressing for you? What might cause some stress? That said, I think it's also important to ask, what is it that's good about your culture? So also to draw on those questions, that there's some in there, that consider the strengths. What kind of pride? What's your ethnic identity like? What kind of traditions are you proud of? Isn't it great that you have bilingual skills? Isn't that wonderful that you're going to be able to, speak and use it for work or whatever it might be? Capitalizing on strengths of generational wisdom, extended family, how wonderful. So not going beyond questions that ask, how is culture distressing to you? But extending it to, how is culture helpful to you? How has your cultural identity been an advantage to you, useful to you? Because that information is going to allow you to consider to what degree you bring in those strengths to your treatment planning. How do you use those to build resilience, to focus on those, to increase self-efficacy? Okay, you can't do it if you're only focusing on the deficit model and how culture increases distress. You also want to ask these questions and think about ways that culture is enhancing and building resilience in their life as well. Okay, so that's one way, cultural informed assessment strategy you can use to try to collect data in a way, information in a way that it otherwise might be overlooked. Okay. Other ways, of course, are using our standardized, culturally informed assessments, using self-reports and clinician-administered measures. Unfortunately, what we know at present is that many of these measures have been normed, you know what I'm going to say, right? Have been normed on non-Latino white populations, and many of them don't have established cultural equivalents in other ethnic groups. So when you look at things, all the psychometric properties and the reliability and validity, and are items being interpreted the same way? When you ask somebody about, are you feeling nervous? Are they understanding it as nervous, or are they understanding it as nervios or something else? So items may not be interpreted in the same way. Sadness may not be interpreted in the same way. I used to do a structured interview where I would ask the question about deprimida. Are you depressed? Have you been depressed for more than, 2 weeks, most of the day, almost every day? And this is with Latina moms, and who had screened positive on the Edinburgh postpartum depression scale, who had very elevated scores. But when in an interview I asked them, are you depressed using deprimida? They would say no. That would be their answer. And then I'd go on and ask other questions. Have you been sad? Have you been crying? Yes, I've been crying. Yes, I've been sad. Yes, I don't want to do anything. But are you depressed? No, I'm not depressed. I'm just these other things, but I'm not depressed. Something is going wrong in our assessments when that is happening, okay? So for those assessments where you don't have cultural equivalents established, it's in everybody's best interest that you follow up to make certain that people are understanding the questions the way you think they're understanding the questions. Okay? That said, there are some measures, and I'm just going to list them here. I'm not going to spend a whole lot of time talking about them because I know we're running short of time. There are some measures that do have some cultural equivalents established for them. I have these listed here. These are cultural equivalents. These are for Latino kids as well. So things like the CDI, the Patient Health Questionnaire for Adolescents, the CESD, although there's some contradictory information. That one study says it may not be have the same factors across Latinos and non-Latinos. There's a couple clinician-administered measures as well. The ones that I put an asterisk by, those are ones that are free and in the public domain, so they're good for settings that have low resources. Vidas et al., who's a dissemination and implementation science researcher, has a whole paper out presenting measures that are free in the public domain and can be used in these settings. It's a big problem when we want good assessment, but the only assessments we can get, we have to pay a lot of money for. It's unfair, it's a disparity, it represents an inequity. It's a problem. So many of these, I shouldn't say many, some of the measures that I'm saying have cultural equivalents are also free and available to use in low resource settings, okay? Okay, let's see. Okay, so these are some for anxiety. A couple of them. The SCARED is available publicly. That might be the only one. And then I also have a list of ones for behavior problems. The Strengths and Difficulties Questionnaire has some good psychometric properties, and again, it's available to use in the public domain. It's not available anymore.
I think they're charging them with our clinic now. You have to log in and
Really? I didn't know that. Okay, it had been available free.
Up until late last year.
Oh, that's unfortunate. Okay. Okay, well, thanks for that update. But some of these others are probably, well, I guess that just leaves you with the brief problem checklist and the pediatric symptom checklist are worth checking out. And also go to that article, the Vidas article, and that'll give you a list of a few others as well. Okay? Okay, I'm going to skip our case study because I want to make certain that we talk as much as we can about treatment, and then I want to present kind of an exemplar treatment in which they've incorporated various cultural factors, okay? Does anybody have questions before we keep going? No? Okay. So, we've learned that we need to engage the client. We need to get them in the therapy room with you. We've learned that when you have them in the room, you want to ask questions that give you important information about who they are as a Latino, how their culture is important, to what degree, if at all, is their culture important, and to what degree might you need to be thinking about integrating cultural factors into a treatment, or perhaps, if possible, using a cultural adaptation if one exists and seems appropriate for them, okay? So I emphasize here the as needed because as I said in the beginning, we know that there's difficulty when we assume a one-size-fits-all approach. We know that adaptations are not necessarily going to be good for all Latinos, for all Mexicans to receive a Mexicanized adaptation, or for all Cubans to receive the Cuban validated version of it, that might not be appropriate, that might be unappealing to some who perhaps don't have similar values, to some that are more acculturated, for some who don't identify with the same issues. So we're trying to get away from that type of approach, and we're trying to get away from approach where you use the evidence, use your conceptualization to guide what type of treatment you're going to use with Latino populations, okay? At present, is that my next slide? I'm sad to tell you that there still is no well-established intervention for Latinos according to those standards that were established in the 90s. Remember, if you've learned about them, the Chambliss et al. Standards, which said whether or not something's well-established, probably efficacious, or possibly efficacious. And you have different criteria for each of those classifications, the best evidence being well-established, and then the probably, and then possibly. So as of 2008, there was a meta-analysis looking at which treatments were well-established for ethnic minority youth. And at that point, there were no treatments. None of our evidence-based treatments that are considered evidence-based for non-Latino white, none of those are actually well-established for ethnic minority youth. When we have revisited, right now I'm working on a chapter with my colleague Armando Pina, and we're revisiting the literature, and we're trying to see since 2008, there's been more RCTs since 2008, what treatments now reach well-established criteria for ethnic minority youth and Latinos in particular. And how many treatments do you think we found? I like your optimism. We found none. There's still none. Still, yeah. So, part of the problem is we're not getting, so the criteria that, and I'm going to talk about this tomorrow, if you come today, you probably don't need to come so much tomorrow to my keynote. Part of the problem is we don't have good enough representation of ethnic minorities, Latinos, in the trials, in the RCTs that are saying whether or not an intervention works or doesn't work. And because of that, we can't do analyses that look at, does it work for some groups versus not other groups? So, we're getting more and more data. So the good news is there are more treatments that are well established, but just we're not getting that data for ethnic minority youth just yet. On the other hand, we do have some EBPs that are classified as probably efficacious, and that is growing incrementally. It's not at a great pace. the ones that are, let me go right here, these top 2 rows, these were the ones that in 2008 we knew they were probably efficacious. So since then, individual cognitive behavior therapy plus parent involvement has been added as an efficacious treatment for anxiety. In addition, for anxiety, we have group cognitive behavioral therapy that's been validated mostly with Cuban youth. For depression, we have CBT, both in individual and group formatted. That's been validated with Puerto Ricans by Bernal and others, and Rosello. So there are some interventions out there that have been validated with ethnic minority and specifically Latinos that are probably efficacious, okay? For ADHD as well, there is from the MTA study, the combined condition, right, where you use the behavioral treatment with medication. That seems to be a probably efficacious intervention for Latinos as well, for Latino kids as well. And then for conduct problems, there's been, certainly a bit more of work done for conduct problems, behavioral problems, and various treatments that we're seeing now that are on their way to being well established if there were more studies that were to be done with these groups. So we have brief strategic family therapy. Has anybody been trained in? How have you liked that?
Great.
Yeah.
I was going to tell you, I think at this point it should be well established.
I know, it's not yet. It's not yet.
A multi-site study that's not there, but the thing is with the multi-site studies that they're comparing it to other efficacious treatments or treatment as social, and it's harder to establish efficacy at that point.
Yeah. So, but then you have to establish better or as good as, and then when you're doing as good as, then you're talking these big trials, these non-inferiority trials that require huge numbers. So that's part of the problem as well. But honestly, brief strategic family therapy has had the most evidence since the 80s as being effective for treating conduct problems, decreasing risk of youth behavioral problems in Latinos. Child-centered play therapy, multidimensional, so some of our family therapies, structured problem solving, PCIT, this one has an adaptation, as well as multiple family groups therapy. So this is a kind of a behavioral treatment. But the interesting thing here is that they're bringing in members of families from, let's say, grandparents' generation, parents' generation, and then the kids, and they're bringing them all together in one setting and delivering the intervention to them as a group in this setting to work on the kids' behavioral problems. So we have, there's hope. I mean, it's promising. As far as possibly efficacious, we have on the horizon IPT. There's been mostly Dr. Bernal's studies supporting IPT, and more recently Dr. Muffson's studies supporting it as being efficacious for Latinos, Puerto Ricans, as well as I believe Dr. Muffson's was mostly Mexicans. School-based cognitive behavioral therapy for adolescents, the Penn Resiliency Program for depression. Again, that's a cognitive behavioral therapy group-based program. And then we have the CBT program for trauma and school-based settings. Okay, so there are a host of interventions. There's some out there to choose from for these problems. Let me just go here. So in absence of data, the question becomes, what do you do if, again, so I was saying there's some interventions that exist. It's wise to go to those interventions first. That's what your evidence says works. So seek out those interventions. If there's not an intervention that works, if you have to use one that perhaps hasn't been tested, you still want to go with whatever there's the strongest evidence for. So it may not be probably efficacious and go to possibly efficacious. If it's not even possibly efficacious, you want to try to look, well, was it evidence-based in other groups? Perhaps if it was evidence-based in other groups, that's a good sign. So you may choose to use that intervention. You want to err on the side of maintaining fidelity as much as you can. So you don't want to change the intervention too much, too haphazardly, and you may not need to change it at all unless you're seeing that there are issues with cultural fit. Okay, if you're seeing that parents and kids aren't understanding a certain concept, parents and kids may reject certain concepts. For a couple of our interventions, our behavioral interventions, the concept of using tangible rewards, monetary rewards, giving candy, giving money, that's very unappealing to Latino families. They don't like that aspect as much. They would much rather use social rewards, praise, extra time with the family, some more social praise, bragging about their kid in front of other family members. That for them, that's a more acceptable form of praise. That's a more acceptable treatment element than these other tangible rewards. So if you're seeing rejection of some of the components like that, that might be important. What we find also is that adding to the intervention seems to be less damaging than taking things away from the intervention, than deleting skills from the intervention. Okay, so this is coming out of some of our recent meta-analyses and some of our reviews, that if you're doing the intervention but supplementing, maybe bringing in some more information about familismo or about acculturative stress or about how hard it must be to be undocumented, that if you're bringing in this content but you're still kind of being true to the rest of the content, that usually has that's usually associated with a favorable outcome. What's not associated with a favorable outcome is determining or deciding, like, I don't think they need this skill, so I'm not going to do assertiveness training because I don't think it's really relevant to them, or I'm not going to do the cognitive part because they probably won't really get it, or it seems like they're having a really hard time understanding it, so I'm just going to skip it. Those types of deletions tend to be a bit more haphazard and result in loss of fidelity as well as poorer outcomes when people are tailoring the interventions in that fashion. Okay? The other thing that we're learning, that's not actually, I didn't put it on here. The other thing that we're learning, and this was based on a meta-analysis of parent management training programs. Oh my gosh, I just lost my thought. So not deleting, oh, I know. So the other thing that we're learning is kind of interesting, and I think it will guide our adaptations in the future. But what we're finding is that what we call deep structure adaptations seem to be associated with better outcomes than surface adaptations. So surface adaptations are those things that we do, like we translate the intervention, we make certain that the vignettes are culturally appropriate, we add dichos or proverbs and refrains, we make certain that there's good cultural examples and cultural names, things that kind of improve how the engagement, how appealing the intervention might appear on the surface. Okay, so those can be important, but what we're finding is that it seems to be that some of these interventions need a bit of a deeper type of adaptation, and that those adaptations seem to be worth a bit more, at least in the parent management training field, than the surface ones. So deeper ones are things where you're trying to incorporate cultural values at at a more structural level. So maybe you're framing things in terms of familismo, you're trying to preserve familismo, or you're bringing in this value and trying to talk to the family about preserving this value and how important this value is. Or you're bringing in more content related to, this is your context, these are your stresses, let's bring this into the intervention, let's deal with these cultural stresses. That there's some information, some data now to say that those types of adaptations seem a little bit better than just changing how appealing it may seem on the surface. Okay? Okay. So let me just, our last 15 minutes, 20 minutes or so, let me just end. I have about 10 more slides. I just want to show you an example of an adaptation from Armando Piña's group called Acercamiento. That's used for phobic kids. Exposure therapy for phobic kids, is that what he calls it? Armando Piña is at Arizona State University, and he spent a lot of time working on the development of this intervention and conducting focus groups to figure out if there were certain themes that would be appropriate, necessary to include in an exposure-based intervention for anxious kids, okay? All right. This is actually a probably efficacious intervention at this point, Acercamiento. It was developed predominantly for Mexican and Mexican-American families in the Southwest in Arizona. And although Armando, did anybody go to Dr. Bernal's talk yesterday? Okay, so this looks familiar. Although Armando did not adapt his intervention based on these elements, you'll see that many of the adaptations that were made do overlap with some of these elements that Dr. Bernal suggests can be important when you're trying to make an intervention culturally responsive. So things like making certain there's a language match, making certain is the individual comfortable with the ethnicity match? Are you using metaphors? Does the patient feel understood? Is the content appropriate? Does the content bring in values to the extent, cultural values, to the extent that the patient likes it, that the patient feels comfortable with that? Are the treatment concepts consistent with the patient's cultural values? So can you to what extent, let's say, might assertiveness training be appropriate in the context of respeto? Do parents want their kids, is that going to be appropriate to teach kids to speak up to their parents in the context of a value of respeto? So understanding how that concept or how that value may be important and whether or not we need to modify the treatment to be consistent with that value. Our goals in sync with cultural values. So again, if our goal is to make the child independent and strong, is that really a shared value that the parent has? Or is that something that we see from our perspective, more from a Western perspective, as being something that should be their goal? So making certain that the goals are consistent with the culture. Are the methods that we're using, are they appropriate? If we're using more of a teaching method versus a process supportive method, does that fit the culture? Do they like that? Do they respond to that? Do they like to have parent involvement? Do they like to have family involvement over individual involvement? Okay. And then lastly, is the treatment considering cultural context to the extent that it needs to? Is it bringing in cultural experiences to the extent that it needs to? Is it bringing in culturally related stressors to the extent that it needs to? So some of these overlap. They're definitely not just discrete elements. But according to this model, these are things you need to be thinking about when you're making your adaptations and asking these questions. So like I said, Dr. Piña didn't really use this as a framework, but many of the adaptations he made are consistent with this framework, okay? So I'm just gonna go through some of those and show you just a couple of the skills that he uses. So yes, from a language perspective, part of the adaptation or the tailoring that occurred, the title of the intervention, which I think is a brilliant title, it's called Acercamiento. And why is that? Why do I think that might be a good title? What's that?
It's one that it's...
Yeah.
That's what exposure is, to approach something.
Is that what you were saying too?
I was saying something different.
Oh, okay. Okay. That's all right. What were you saying?
Well, I was saying like that maybe it's getting close to a good intervention for Latinos.
Oh, that's what you're saying. That too. But yeah, it's this idea, that's exactly what exposure is approaching, getting closer, bringing together. And you'll see Dr. Pina frames this very much as a family influenced intervention as well, so that as going through this treatment and doing this doing this type of therapy, it's also going to bring you closer to your family. It's going to unite your family. It's going to make your family stronger. So that's also acercamiento, kind of coming together. In addition to, yes, exposure is exactly this. So titling the intervention as appropriate, including bilingual, bicultural staff. He had therapists who use Spanish or English depending on preference, as well as acculturation level in the English language proficiency of family members. So that was a question that's asked early on. And you have to do, who's ever doing therapy, or I don't know how many of you guys do therapy in both Spanish and English. It might involve doing in Spanish with the parent, English with the kid, and then doing some code switching throughout the process, going back and forth as well. All materials were available in English and Spanish. So, some of these are more surface level adaptations, right? And usted for parents and tú for children. That might change in later phases of the intervention. If there's enough of a comfort level, they may have decided to go to tú, the familiar form for both, but better safe than sorry. They most often stuck with usted for parents and tú for kids. So this was kind of the language part of it. The person's part of it, there wasn't necessarily an ethnicity match. And from what we know in the literature, that doesn't have to happen, right? It's not as important that you have to be the same ethnicity as it is important that you have to speak the same language. I mean, that's more important. Having a language match is more important than having an ethnicity match. Here, treatment was delivered by bilingual and bicultural therapists. They had knowledge and experience working with Latino populations, so they knew information about values and customs and traditions. That's what sensitized means. And they were supervised by a bilingual and bicultural supervisor. So that's a person's component. They would use metaphors and dichos, so again, a little bit more some of the superficial adaptations. So acercamiento, coming together, the family united. That was an idiom for treatment, very clever. They used a symbol of Mexican culture, the pyramids, instead of our fear hierarchy. So that was a nice cultural replacement. They used dichos and sayings and proverbs. How many people have heard this one? El miedo tiene mucha imaginación y poco talento. People heard that? I hadn't heard it before until I read it in the manual. No? Okay. Fears are rich in imagination and poor in intelligence. The therapist asks the child to explain dichos like this as part of the intervention. What is a dicho? What does that dicho mean?
A lot of rumination and nothing, they cannot do anything.
Yeah, they're not good for anything, right? They might be rich, they might be vivid, they might be very colorful, your fears. So there's lots of imagination there, but they're not very smart either. They're not very rational. They're not really good for anything. Yeah. So what other dicho did they use? I forgot what other one they used. So that's what their pyramid of courage looked like. I think that's kind of cool. Instead of doing your ladder, you have the different steps that you create with your pyramid to get to your final goal. This was what your fear worksheet looks like. It's titled with your dicho. What were you thinking? What other thing could have happened? How did you test it? And what happened? So, I mean, there's nothing too different about this except you have your dicho, and actually some of the worksheets, they say si se puede on the worksheets, and that's kind of a nice cultural adaptation to encourage the kids as well. As far as content goes, so here's where there's a little bit of what I was talking about. It's more of a deep structure adaptation. The intervention was included the value of familismo as being core to the intervention, as being very important for this population. And this didn't come out of nowhere. I mean, some preliminary work was done with focus groups, preferences, asking parents and kids, do you want the intervention delivered in group format or individual format? Do you want your parents involved, yes or no? What values are important to you? So there was a values assessment prior to developing the adaptation. And out of that came this recurrent theme that family is important, that family is a motivating factor in this community of Mexican and Mexican-American youth. So in this approach, they incorporated aspects of Latino culture that they thought could facilitate treatment engagement in the way that the intervention was implemented. So familismo was used to encourage the kids to do the exposures, to attend session and to help with exposures. And it was incorporated in a sense that the exposure and therapy was framed as this is for the good of you, but this is also for the good of your family. Therapy is kind of a collective process. It's a community process. You're all together. You're all working together because you want la familia unida. You want a united family, and that there's good things about having a united family right now. It talks about there's sources of distress that are occurring within the family that are related to the anxiety. It might be, the parents are getting upset with the kids, or the parents are yelling at the kid a lot because of the anxiety. So given the importance of family for their culture, or for given the importance of family in their home, that you want to try to encourage them to do the exercises for the betterment of family, for the betterment of interpersonal harmony, so that you have more social support, because that is something that brings you together. That's what acercamiento is about, okay? So I put here too, that this is where a prescriptive approach can be important, because what this intervention allows for and encourages as well is some backing off if family isn't the be all and end all, or isn't the most important thing. Okay? So it allows some of that assessment to occur, and perhaps a little bit of not emphasizing family to the same extent across all Mexican families. That, it's not a one size fits all, and that you're going to try, even with your adaptations, you could try to tailor them from what you know from your cultural assessment, from what you know of the cultural values. You could try to tailor it to be appropriate for that individual family. Does that make sense? Yeah? I mean, it's easier said than done, I think. I think, you know, it requires that you're a somewhat skilled therapist, you have good clinical judgment, you're able to understand how important this cultural value is, and to what extent should I stay with this cultural value, or to what extent, you know, is it not as relevant in this group? So I think I don't think it's certainly doable, but I think this is where the clinical judgment comes in. This is where EBPs are not cookbooks. You can't just take the book and deliver it as is and think it's going to do a good job. That what you bring to it and your knowledge and your expertise make the difference between whether or not it's, you know, a good recipe that you develop, or if it's something that's, you know, not so great or just kind of mediocre. Okay, so as part of it, they're participating in therapy to help self and help family. The family responds with praise, affection, telling friends about accomplishments, and you're encouraging social support from within and outside the family. So as part of this, they do this convoy mapping task where not only, it recognizes that in Latino families, it's often beyond the immediate family, that there's extended family members and extended family support. So in addition to your family helping you, or you going to your family, there might be other people that you could rely on. There might be other social supports in your system that you could bring into your circle, or that you could get closer to. And it's important to think about this when you're planning your exposures and when you're doing your exposures and getting people to help you do your exposures, that it doesn't only have to be your parents helping you do these things, that you could widen that net and include other people to help you do these exposures. So Dr. Pina has this list of questions. Who do you talk about? Things that are really important to you. Who makes you feel better when something bothers you? Who takes care of you if you were sick, etc. And with that, you know, he has the kids do this task where they're doing concentric circles. The people in the middle are those that are closest to you, and then those on the outside, maybe they're, you know, you go to them, but they're not as close, and then you even have people on the outer circle. Now, these are people you call on to help you with exposures. This is a made-up one. I always wanted to name my daughter Lola, so I called this patient Lola. And so, you know, you have people in the middle, and then you have godparents perhaps and grandparents on the periphery, and then on the furthest it might be tias and uncles and other cousins. These are people you call in to facilitate your exposures, to praise you when you do something. Hey Thea, I just did this. I was able to go to the dentist, yay. So you get praise from lots of other people besides just your immediate family, okay? Consistent, consonant with the importance of family, familismo, social support, interpersonal harmony. Okay, so it makes sense. More of a deep structure adaptation. Now for this one, Dr. Pina and Asmt did not include this type of content so much as an adaptation. I'm sure they would have addressed it if it came up, but it wasn't like a standard part of the treatment that you're always talking about migration history or separation from family members or experience of discrimination. That may have come up in the beginning, because remember I told you there's a bit of a cultural assessment that happens in the beginning. That may have come up, and if so, you're prescriptive and you tailor the intervention as appropriate to address these issues. But in this intervention, it's not necessarily that you're going to be talking about this content with all families. Okay. Constructs used within the psychosocial model, are they framed within cultural values? So this one I've already mentioned is assertiveness appropriate in the context of respeto. If a family's high on respeto, do you emphasize assertiveness to the same way or not? There's this other one, this idea of parenting style. What's an appropriate parenting style? What should we be educating our families, our Latino families in particular, about parenting? I mean, typically we tell people overprotective parenting, over-controlling parenting is not good. It leads to anxiety because you're teaching your kids that the world's a scary place, that they can't handle it alone. I've said it over and over again to families. The data doesn't work so well. That doesn't bear out when you're talking about Latino families, because the interpretation of overprotective parenting in Latino families is very different. Overprotective parenting can be perceived, I mean, this is only one study, so I recognize there's limitations there. Actually, it's been a couple studies. But it can be perceived as something positive, as a sign of warmth, as a sign of love, as a sign of being consistent with family obligation, that, you know, this is a good thing. So this is something that, you know, that concept is challenged in some of our adaptations with Latino families when you're talking about parenting and the significance of parenting, okay? Again, here it was this controlling parenting associated with higher anxiety in non-Latino white kids, but lower anxiety in Mexican American kids, okay? It's consistent, it's likely more consistent with their cultural norm, with their cultural value, okay? Okay, just a couple more. Again, are there shared goals? Parents' goals and kids' goals the same? Are they different? Do they respect the values of familismo? Yeah. And here's probably where more discussion, if it was going to be an issue, more discussion of intergenerational conflict could pop up here. This idea that, you know, maybe a kid with anxiety wants treatment because they want to be independent, they want to go to more parties, they want to do more things, they want to have their freedom, and that's not necessarily why the parent wants their kid to be less anxious. Their parent might want it so that, you know, they're happier, their mood's better, they could go with them, they could do their quinceañera or whatever it might be. You know, there's different reasons. So being able to navigate and understand what those differences are in goals and how to see value in both the parent's goal as well as the kid's goal, and to try to help with some perspective taking. I mean, that's kind of classic bicultural effectiveness training, which also came out of Dr. Sabachnik and Jose Santisteban's, Dania, came out of their work, this idea of this bicultural effectiveness training to really frame the problem in terms of this is a problem of differences in culture, not necessarily a problem of differences in parent and child. So it's kind of externalizing. It's more about the culture and less about you. That's where something like this might be appropriate. Okay. And then again, are you using the right methods? Is it, in acercamiento, it was more of a didactic approach. It was framed as building skills. The therapist was a coach and called a coach. There was parent involvement because that's what they found out from their early studies, that the kids wanted to be involved and the parents wanted to be involved. So appropriately, there was parent involvement. And again, a method that they used specific to making this adaptation was to better understand cultural factors in the beginning of the treatment so that they know how to tailor within the adaptation if necessary. Okay. And lastly, again, this one's a bit overlapping with some of the others. Did they consider processes like a culture rate of stress, migration, social support, and relationship to country of origin? Yes and no in some ways. Like I said, not uniformly across all kids, but as necessary, yes. And there were some underlying themes such as familismo and personalismo, and recognizing the importance of spirituality that they did encourage. For example, you know, therapists were prepared to incorporate things like prayer, praying to God before an exposure, praying to God for courage. Of course, I say that also knowing that we don't want kids to be using these things as safety signals or in an obsessive way, that the only way they can do it is if they're praying. But aside from those constraints, it would be perfectly appropriate if in a family where spirituality is valued, that you bring in these elements of spirituality to the treatment. Okay? And I already said this is the idea of us trying to do more personalized approaches. Even though we're doing adaptations, there could be room for tailoring and prescriptive approaches within the adaptations. I think there's precedent for that already with Kristen McKay's PCIT intervention for kids with behavioral problems. I think there's precedent with some of Dr. Pina's work, and I think that's probably an area that the field is going to try to go in that direction in the future. And that's it. Thank you. This is my lab, or some people from my lab. We're not all there. This is at our favorite Oaxacan place in Los Angeles, Guelaguetza. If anybody goes to LA, I highly recommend it. It's a good, fun place. Live music, good moles. Yeah. Okay, any questions? I told Danielle, I was like, I don't know, Danielle, I don't think I have 2 hours worth. I'm not gonna get through it. Is it okay if I let them out early? Do I have to have a break? But apparently I was wrong. So, any questions? Yeah.
I wanted to ask about some recommendations that you might have with families where maybe the parents moved to America as adults and their children were either born or raised in the States, and dealing with feelings of isolation if they happen to be an ethnic minority in the place that they live, and that child is an adolescent, they have this need for sameness, but they feel isolated because the culture and values that they hear at home are a little bit different than maybe what they hear at school or what they hear from their peers.
Yeah.
And that need for sameness is, causing them to rebel against what their families or values are, and how do I bridge that?
Yeah, I think it's hard. Yeah, it's really hard. What we typically do is we go with that strengths-based approach. Like, what is it about them that's a strength? How is their culture something positive in their life? And how can they take that strength from their culture and bring it to who they are and use it to their advantage? Also working with the parent to help the parent understand that their kid wants to fit in, that this is what's normal in their life. This is what's typical. This is what's expected from kids in their life, and that this is important to your child. This is a value to your child. So it's about that bridging, helping parents to understand what their perspective is and giving kids that freedom to be more like their peer group, if that's part of the problem, is that parents aren't allowing them that. But also at the same time validating and recognizing to parents, we see the strength in your culture and your tradition and what you're teaching your kids. Isn't that beautiful that you're doing that with them? At the same time, they have to be able to move in two worlds. So how can we most effectively make them be able to move in two worlds? I mean, that's kind of how we approach it. Other people have suggestions, what you've been doing? I take that kind of bicultural effectiveness approach. I don't know if other people have different suggestions.
Please.
What?
I said please to everybody if they have.
I've run into similar problems where it's
Yeah.
the child really wants treatment and the
Yeah.
parent is not that engaged because of their cultural beliefs, where the child is more cultured, so they don't have a problem with it.
Right.
So that affects their ability to get to treatment and be engaged and stay in it. And it's hard to bring that up with parents and get them on board.
Right. Do you think any of that engagement stuff that we went over would be helpful, or any of the motivational interviewing stuff? Could that be helpful? And
I think it definitely can be in cases where it has helped. There
Yeah.
are other cases where it really hasn't
Yeah.
So I think there's still a little bit of that gap figuring out what that is. I think there's some of it where it's a lot of mistrust of maybe things that are considered, that's like social services and things like that, and all these things that are outside the community necessarily. I know that's been a big issue where there's just kind of this keep you at a distance because we don't know what you're going to do to us.
Right. Confidentiality is a huge issue that it takes time to build that trust. I think trying to kind of provide that information that what this is, how this could be helpful, how this can make you stronger as a family, as a person, as a parent, and then in the context of reassurance that trust is there, or recognizing too that might be a concern for them. So kind of putting it out there and seeing what their reaction is to that. If you talk quite openly with them about issues of trust, or if they've been discriminated against in the past, and do they have concerns that that's going to happen again, or do they have concerns that there's going to be betrayal or loss of confidence in some way. I think I would try to tackle it from that perspective as well. Yeah. Other thoughts?
I was going to ask
Yeah.
you about the use of interpreters.
Yeah.
So I've had mixed success with that, depending on who comes in, and a lot of times it's not the same interpreter.
It's so hard. The data suggests that use of interpreters actually can lead to less favorable outcomes because it's just putting more distance there between you as a therapist and them as the patient.
Are there any strategies that you know of to increase engagement while using an interpreter, if that's really the only option? Because a lot of times in the community environment, that's kind of the only option.
Yeah.
Should at least get
That's a
parents
good
involved.
question. Yeah. How do we increase engagement when they're using an interpreter?
That doesn't turn out that well.
No, you never want the kids to have to do the interpreting. That's too much pressure. That's too much pressure for them. I don't know. Has anybody had that experience? We haven't used interpreters, so I haven't.
I work in a school, and some of the families that I work with, the parents only speak Spanish and I don't speak Spanish.
Yeah.
So I will have the staff members, of the school, help me talk to the parents because I can't.
Mm-hmm.
It doesn't work. I try to have it be the same staff member every time, but
Yeah.
there's I can't think of any other. I'm trying to learn Spanish right now.
Mm-hmm.
But that's gonna take some time.
Yeah, but that goes a long way too. I mean, if even parents see you're making a small effort to try to speak Spanish, I think that could help with engagement in the context of all I have is an interpreter. If there's still that overarching, perhaps personalismo that you're still trying to bring to the interaction, it may not be through language proficiency, but there might be other ways that you could convey that kind of warmth and trust. I don't have a good answer to your interpreter question, though. I'm sorry. I'll think about it on my flight home. I promise.
If I can just
Yeah.
add, because I've been in the, had the experience of being the interpreter where
Yeah.
I wanted to be the therapist, but at the time I was a student and they were running a trial, and I'm not gonna say where, but they asked me to be the interpreter, and I can tell you from my experience, even though I was able to provide good interpretation of what was happening, we lost those families.
Yeah.
And because we were, they really wanted to have me as a therapist, and they knew they weren't gonna be able to. So I think it's recognizing that they're, and letting them know that there's limitations and you're aware. I think sometimes we're scared to bring up something that is so obvious, and we don't say anything about it. So maybe, acknowledging that this is something that must be very hard for you to have to talk to me via an interpreter. I really, I wish it was different, but I really want to try to help you the best way that we can, and this is the only way we have right now.
Mm-hmm.
And,
Mm-hmm.
So just so that, they feel comfortable and they understand that you realize this is not the most comfortable situation, but you're there to try to help them. I think that conveys that,
Yeah.
I'm here for you, and I understand this is not the ideal situation.
Yeah. Yeah, that's a good suggestion. Yeah. Yeah, I haven't seen anything that looks at engagement when you're using an interpreter. It might be, I would think something must be out there though, because it does happen enough in certain states where you don't have a lot of Spanish-speaking therapists. I mean, we know our bilingual workforce isn't increasing at the numbers that we need it to increase in order to meet the needs. But it's certainly going to be a very relevant question, more relevant in the future, yeah. Other thoughts, questions, comments? No? Yeah.
I have a question about integrating family members other than parents into treatment. I've had sort of a mixed bag of like motivation where sometimes the parent's the one motivated, sometimes it's the grandma, sometimes it's the aunt, and the parent is saying yes to treatment, but the grandma or the aunt is more so the agent of change. So how can I include them while still respecting the parent's authority?
Oh yeah, we do it all the time in our work. The grandparents are often the ones who we're doing the intervention with. We're keeping the parents in the loop though. We're always giving parents updates and checking in with them and saying, you know, we're doing this with your child and grandma's doing this and this is what's happening. So we're giving parents progress reports, but grandparents and godparents, Ninas and, well, mostly Ninas, not Ninos, not yet, but they are often the agents of change in the work that I do in Imperial Valley, in our rural community. So I haven't had an experience yet where it seems like we're, you know, kind of usurping the authority of the parents. And I think it's because we work probably extra hard to make certain that they're involved and that they're getting updates and progress reports. And even though they may not be the ones who are going to do the exposures, we still tell them what the exposures are, and we still encourage them to praise their kids for exposures that they've completed or practices that they're doing, so that there's some type of cohesiveness in the delivery of the therapy. Have other people had positive or negative experiences with including family members?
For like me as a non-Spanish speaking person, it's been challenging when I wanted to include another member of the family, but that grandparent maybe doesn't speak English.
Yeah.
So that's been a challenge. And then, of course, we have some resources where we can include a Spanish speaking therapist, like one of these guys.
Yeah.
But then it's another person, and it feels a little bit disjointed at times.
Yeah.
So we're like, we can give you Spanish materials, but it's definitely a challenge.
Yeah, it is more of a challenge. Although there is precedent in the OCD literature for having your behavioral coaches, right? So you might have the main therapist, and then you have another person doing more intensive exposures. So, I mean, your Spanish-speaking therapist can be seen as a supplemental, an extra coach, but as long as you're the main coach kind of driving everything, I think that could work out. Yeah.
I think I've had a positive experience just in the parent group that we facilitate in the after-school treatment program. In fact, I've had the experience where parents are like, "Oh, I wish I could bring my mom because she's the one that needs to help me with this because she's the one that spends the most time with my child." So I think it's very much like that desire to include the extended family, and they're pretty. I mean, they integrate well.
Yeah.
We do the group in Spanish.
Okay. Yeah.
Yeah, obviously that helps.
Yeah, no, that does. And, whenever I hear parents say that, I say, by all means, bring them along. Or do they want literature? I'll give you an extra manual for them. And look, it's available in Spanish. So even if you may not be able to speak directly to the person, there might be just information you could give them. Or you could always, have maybe a coach do a conjoint session with you a couple times. Okay, thank you very much.